Well, I'd like to thank the organizers and Dr. Zabir Younasi for that very generous introduction. Not quite chief of GI at Mayo Clinic, but thank you very much for that. But it's a true honor to be here with you today, and thank you for pulling me out of the tundra of the winter in Rochester, Minnesota. And I think my talk is going to dovetail very nicely into that brilliant talk of Dr. Brill. So I'm going to be talking about the medical management of MASH with a specific focus on liver-related endpoints and outcomes. Here are my disclosures. I have participated in many different studies over the course of my career, and so do have several conflicts, but none specific to this presentation today. So in the next 20 minutes, we're going to talk about and do a deeper dive in the newly approved FDA treatment options for MASH with a specific focus on Resmetirom and Semaglutide. And then I'd like to review the therapies that are approved for complications of metabolic syndrome that have been shown to have a benefit for NASH, although are not FDA approved for this indication, that are in your toolbox for use. And as you can see here, they are therapies that Dr. Brill actually did bring out in his own talk on metabolic syndrome. So the first FDA approved therapy was Resmetirom. And when this got approved on March 14th of 2024, it really set a very different precedent. It was almost a watershed moment in the therapeutic landscape of NASH, and not almost, it was a watershed moment. It was indicated and received a label that it was indicated for the treatment of patients with moderate to advanced fibrosis, F2, F3, no biopsy requirement, and this underscores the landscape that Dr. Kunwal identified with the use of NITs. Once daily dosing, simple dosing regimen based on weight, no contraindications, no black box warning, no monitoring requirements beyond standard of care. And here we had a new precedent that really created a huge emergence in the field. So what is Resmetirom? This is an oral, liver-directed thyroid hormone beta receptor agonist with no alpha effects. The alpha effect causes the thyrotoxicosis and extrahepatic manifestations of hyperthyroidism. But we've come to identify that in patients with MASH, the concept of having chronic liver disease renders low thyroid hormone receptor-beta activity inside the liver, and this lower activity exacerbates mitochondrial dysfunction and lipotoxicity. So thyroid hormone beta receptor agonists actually work on several different hepatic pathways to maintain liver health. They improve de novo lipogenesis and fatty acid oxidation, mitophagy and mitochondrial biogenesis and cholesterol metabolism. And through all these effects have a direct anti-inflammatory, anti-fibrotic effect, and can correct, in fact, what we now understand is intrahepatic hypothyroidism. And so intrahepatic triglycerides drop, and we can achieve endpoints of MASH resolution and fibrosis regression. And when the approval for Resmetirom went to FDA, Madrigal, to their credit, had an abundance of data. They had an open MAESTRO-NAFLD-1 study, which was really a real-world non-invasive trial, only using non-invasive measures of disease activity, and really done also for safety. An open label trial that wound up also including 200 patients with well-compensated cirrhosis. But the registration trial was this MAESTRO-NASH study, which was a biopsy endpoint trial that needed to demonstrate improvement in steatohepatitis without worsening of fibrosis, or fibrosis improvement without worsening of NASH. And this study is continuing to go on because we're trying to achieve clinically meaningful endpoints for full registration FDA approval. But there's also the MAESTRO-NASH outcomes trial, which is evaluating the role of Resmetirom in well-compensated patients with cirrhosis, and so more to come. The registration trial, the MAESTRO-NASH study, was adults with biopsy proven, at that time it was called NASH, but they had to have evidence of ballooning, inflammation, fibrosis stage 2 or 3. This was a parallel trial that evaluated placebo versus 80 versus 100 milligrams of resmetirom and went to 52 weeks with a subsequent biopsy. The primary endpoint was MASH resolution without worsening of fibrosis, or fibrosis improvement without worsening of MASH. And when we take a look at this data, we really have to look at it with the lens of placebo-corrected response rates. So as you could see for MASH resolution, the placebo-corrected response rate was about 20%, and for fibrosis improvement without worsening of NASH, about 12%. So one can say, well, those are pretty small margins, but when you think about the population at risk being so huge, this was really substantial. And as you can see here, there's an improvement in liver biochemistry with AST, ALT, GGT, and incremental improvements over time in MRI PDFF, CAP score, liver volume, spleen volume, and even liver stiffness, suggesting potential improvement in disease activity. When we take a look at the data in this kind of Venn diagram, you could see that patients who had biopsy-proven NASH in this little orange circle here, as well as patients who had a 30% reduction in MR-PDFF, the overlap of the two approached almost 30%, whereas in the placebo-treated arm, the overlap between the two was only 5%. So in the resmetirom-treated patients, 90% of week 52 biopsies were also patients who had a 30% reduction in MR-PDFF, suggesting that indeed non-invasive measures and significant liver fat reduction can correlate with histologic improvements in disease, whereas there was really no association with MASH response in biopsies in patients who were in the placebo group. But what was very encouraging about this therapy in clinical practice, it was really agnostic to any other risk factor. It was agnostic to age or gender or the presence or absence of diabetes. It was agnostic to the severity of NASH on the baseline liver biopsy. And although it's not shown in this slide here, it's also agnostic to PNPLA3 status. So it can be used broadly without concerns of pre-treatment predictors of treatment responses as far as we know currently, and had a very favorable cardiometabolic lipid profile. And this is important, understanding that our patients are more likely to die of cardiovascular disease before they potentially have clinically meaningful outcomes from their liver disease, a reduction in LDL cholesterol and lipoprotein a. So the FDA clearly liked that. Now, the predominant safety profile of resmetirom, approximately 20 to 30% of patients may have early symptoms of loose stools or diarrhea and some early symptoms of nausea. And in my experience, this really does dissipate over time and usually has resolved by 8 to 12 weeks of treatment. Otherwise, no significant side effects. So who should we be treating with resmetirom? Now this opens the arena of how do we use these non-invasive tests. Patients who are unlikely to develop a clinical outcome and have simple steatosis don't need treatment. And this puts us in a situation where we really need to identify those patients at risk without bleeding into those patients who are likely to have cirrhosis. So the use of NITs, as you could see here, is you can use VCTE, 10 to 20 kPa. You can use MRE, about 3.3 to as high as 4.9. You can use ELF score, but if we can target these patients at risk, they're otherwise eligible potentially for treatment with resmetirom. And you've seen this slide here. The use of NITs can be utilized to assess treatment response. What we do in clinical practice is we'll check liver enzymes at about 3 months to ensure there's no liver toxicity or increase. We'll assess tolerability. I'll work with my patients on resolving or treating some of the early side effects with anti-nausea therapies or Imodium if they were having some loose stools. And I follow them over the course of time at 6 months and at 12 months to assess for a potential treatment response. And I'm really looking for normalization of liver aminotransferases, a 30% reduction in VCTE stiffness, or reduction in 30% by MR-PDFF. And if they have these endpoints, I continue. If they are stable from their baseline, I may consider continuing. And there is data that is emerging that maybe some patients will have a more delayed treatment response. And if there's clearly worsening in their NITs, I likely will stop therapy and rethink of alternative strategies. Now, those alternative strategies, of course, we have a second therapeutic, GLP-1, in the form of Semaglutide. And as has already been demonstrated, highly pleiotropic compounds. These decrease weight, they decrease de novo lipogenesis, they improve glucose uptake in the liver, they slow down gut motility, and patients will feel a sense of satiety very early on with eating, and they also improve pancreatic insulin secretion. So really great class for anti-metabolic systemic therapeutics. Keep in mind that the liver has no GLP-1 receptors, or very little at best, and so these class of drugs is not a direct intrahepatic as it is a secondary downstream effect on the liver disease, with maybe a very small effect that's independent of weight loss. So the Essence trial that is done and is still ongoing was a steady dose escalation of therapies of the dose of Semaglutide to a target dose of 2.4 milligrams subcutaneously once weekly. Part 1 was 800 milligram, 800 patients treated, and Part 2 is 1,200 patients treated. And we've seen the Part 2 study results. As you can see here, the patient demographics was comparable between Semaglutide and placebo. These patients had to enter with biopsy-proven MASH with fibrosis stage 2 or 3. And it's been shown the average weight loss was about 10% in patients with biopsy-proven NASH. They felt better. And who wouldn't if they, you lose weight and sleep better and feel better about your overall health. And there was an associated reduction in AST, ALT, liver stiffness, ELF score, PRO-C3, and so there was non-invasive assessments. The placebo-corrected response rate for MASH resolution approached 30% here, and for fibrosis regression, about 14%. And when you take a look at both MASH resolution and fibrosis regression, placebo-corrected response rate was about 16%. So again, the AASLD has published who do we treat and how do we follow these patients. And I would argue that maybe the target treatment, because now you have these therapies that are approved both for liver disease, but also have approvals for obesity and diabetes and even sleep apnea. We're targeting those patients who have at-risk NASH, those with fibrosis stage at least 2 or 3 if you're using it as a liver-directed pharmacotherapy. You can also use NITs to evaluate these patients. You may want to consider treatment that can be used in patients who have VCTEs up to 20 kilopascals or an MR elastography up to almost 5, as was, and this does mirror the Resmetirom AASLD guidance for use of Resmetirom. So no really different suggestion. And it is, again, not recommended in patients with well-established cirrhosis, specifically for the indication of their liver disease. We do worry about sarcopenia, and if patients become too hypoalbuminemic, the risk of ascites. So be cautious in use with patients with cirrhosis. And again, almost a mirror image of the assessment of safety in response to therapeutic on Semaglutide, where you want to do an early assessment of safety and tolerability, address side effect profiles as they emerge, follow patients now, because the study is not 52 weeks, it is 72 weeks for a treatment endpoint at that timeline in accordance with the Essence trial. Continue Semaglutide if patients are getting a good response. And I would argue, even if there was a suboptimal response, if patients are achieving weight loss, improved glycemia, lower lipids, you are getting a therapeutic benefit in patients who have cardiometabolic risk and worth continuing, and potentially, if based on tolerance, cost, or the lack of improvement, consider discontinuing semaglutide. So the safety has already been discussed by Dr. Brill. All I will say is the safety profile in patients with chronic liver disease looks exactly like the safety profile of patients without chronic liver disease who are being treated with obesity and diabetes. So no other concerns there. So what else is in our toolbox? Well, when we approach patients with MASLD and MASH, of course, we tackle each and every one of their risk factors, their weight, their exercise, their diet. We decrease alcohol, we decrease fructose, we increase maybe coffee, and we address each and every one of the metabolic risk factors. And people don't sometimes recognize how many tools they have in this space, and I'm going to share those with you here. One of the added tools, although it is not approved for the indication of MASH, is Tirzepatide. The dual agonists are receiving a lot of attention, and there has been this synergy study that was recently published by Rohit Limba. And this again evaluated adults with obesity, with or without diabetes, who had biopsy-proven steatohepatitis with fibrosis. Again, a steady dose escalation to tolerance over approximately 16 to 24 weeks, and then a continuation at their randomized dose, with the primary endpoint being resolution of MASH with no worsening of fibrosis. And as you can see, there's several secondary efficacy endpoints, including fibrosis without worsening of MASH, 2-point improvement, or changes in their non-invasive tests. And the wow factor here is as we start seeing the dual agonists and potentially even down the road the triple agonists, we're seeing a more pronounced anti-MASH response, now almost here with a 50% placebo-corrected response rate, 40 to 50% at the different doses from 5 to 15 milligrams, and nearly a 20% placebo-corrected response rate for fibrosis regression. And as has already been shown, a slightly higher weight loss effect with Tirzepatide than we're seeing with Semaglutide, almost 15% here in the MASH studies, with improvement in ALT and AST, and also secondary improvements in the non-invasive measures, the MR-PDFF, the CT corrected fat scores, the VCTE, NIS4 as a blood-based biomarker for steatohepatitis, ELF, and even PRO-C3. We have also in our toolbox interesting data that's emerging with SGLT2 inhibitors. Now, this class of drugs is interesting. It causes a glycosuria, it improves blood pressure, it improves cardiac contractility, it affects potentially renal fibrosis. It is a good anti-metabolic therapy that many of our endocrinologists and cardiologists are resorting to. And at least in NASH trials, although many of them did not have biopsy-proven endpoints, it decreased weight, it decreased lipids, it decreased glycemia, it decreased ALT, abdominal fat, MRI-PDFF, liver stiffness. But there was one study that was published really just this past year, multi-center, double-blind, placebo-controlled trial, 6 centers in China, used dapagliflozin 10 milligrams versus placebo in a phase 2 trial with biopsy-proven endpoints. The primary outcome was improvement in NASH, and here you could see nearly a 20% placebo-corrected response rates, with the secondary endpoints being MASH resolution without worsening of fibrosis, again, statistically significant, and fibrosis improvement without worsening of NASH. So can SGLT2 be used in your armamentarium of NASH therapeutics, especially if there's an alternative indication for use? The answer is absolutely. We can't forget the use of vitamin E or pioglitazone, although I gotta say I haven't seen much use of pioglitazone in the era of GLP-1 therapies, but the pivotal study by the NASH CRN, the PIVENS trial, did demonstrate MASH resolution with both vitamin E in the form of alpha-tocopherol as well as pioglitazone, but did not achieve the endpoint of fibrosis regression. And Dr. Brill, when he was at the University of Florida, did a comparable study in patients with diabetes. And again, you can see that at least combination therapy of vitamin E with pioglitazone improved MASH, as did even vitamin E. So what about ACE inhibitors? This was a very interesting study because this was a target trial emulsion study that used real world data. They wanted to evaluate whether ACE inhibitors or ARBs decrease liver fibrosis in humans. We know it does in animals. And they aim to evaluate this in patients with MASH using the TriNet-X national database, huge database, and they did propensity matching. So this database contained over 16 million patients. They excluded anybody who had a major cardiovascular event, major liver-related event. They stratified patients by those that got ACE inhibitors or ARBs versus calcium channel blockers. They did propensity matching, and they came up with about 7,000 patients in both comparative arms. But what was really interesting here is that the endpoints of death were lower in those that had received the ACE inhibitor or ARB compared to the calcium channel blocker, and the major adverse liver-related outcomes were also lower, irrespective of risk factors in those that had received the ACE inhibitors, but how much lower? There was a decrease of about 30% in liver-related outcomes in this propensity match study, a decrease in almost 20% in major cardiovascular endpoints, and mortality nearly 40%. So we should be using ACE inhibitors if there's an indication. Also consider the use of statins in your armamentarium. These are highly pleiotropic medications. They affect microcirculation, have an anti-fibrotic response, antioxidants, protective effects against liver cancer, and in a meta-analysis, at least statin therapy suggested a benefit against hepatic steatosis, against steatohepatitis, and even against fibrosis. And lastly, one drug that is not effective in steatohepatitis, but does potentially have an effect on all-cause morbidity and mortality because there's evidence that it decreases liver cancer in patients with diabetes, and that is Metformin. So I agree with Dr. Brill that it could be in your armamentarium of use, and it does increase liver cancer survival, which we know is high in our patients. So in summary, reversal of MASH and improvement in fibrosis is feasible with both Resmetirom and Semaglutide, and effectively use the NITs to evaluate treatment response. We're moving beyond the biopsy. Both of these therapies are approved only for F2 and F3 fibrosis, no efficacy endpoints yet, or approval for cirrhosis. And there's a large percent who are clearly non-responders with both of these therapies. And so invariably, the treatment landscape is going to consist of combination approaches. Timing and early detection is everything, and as I showed you, you have a full toolbox of many therapies you can use. Pull all the tools out of your toolbox and effectively target and treat the complications of metabolic syndrome with therapies that hold potential efficacy for MASLD and MASH in addition to use of your FDA-approved drugs. Thank you very much.